Thank you very much. As Sophie mentioned, my name is Niki Matinrad. I'm a PhD student at Department of Science and Technology, RTN, at Linköping, and I will be presenting a working project on which I'm working with Vangelis Angelicus and my supervisor Tobias Andersson Granberg. Both are from ITN, and also Niklas Ennapvogel, who is a PhD student from Department of Medical and Health Sciences, and will participate in the presentation today. So the presentation is about optimal dispatch of emergency volunteer resources, more specifically SMS lifesavers. As emergency services are facing limitation of resources and cutbacks on that, and on top of that, the long distance to sparsely populated areas, we will be needing some new initiatives on resource utilization. For that, one of untraditional type of emergency resources that has been facing rising interest is volunteers. And there have been some projects utilizing volunteers in daily emergencies, and by daily emergencies I mean emergencies that are highly frequent but low in size, such as cardiac arrest cases or traffic accidents, building fires. And there are also reports on utilization or show up of volunteers on disasters, spontaneous volunteers, so to be called, that we can see both in news and also in the literature. So if we want to categorize volunteers, we can categorize them into established and emergent. Established, such as Red Cross and Red Crescent volunteers, and emergent as spontaneous or bystanders. And what volunteers can potentially benefit will be that they have lower cost compared to professionals, and also they might have better accessibility to emergency sites. One of the project initiatives is SMS Lifesavers, or SMS Livradore, if I pronounce it right, which started back in 2010 as a research project in Stockholm County. It's a private-owned project by private stakeholders and investors, but Karolinska Institute and Unified Messaging System are partners in this project. Right now, this project is operational both in Stockholm County and Västra Götaland County, Göteborg. And in this project, there are some volunteers who are capable of doing CPR, utilizing AED defibrillators. They are registered in the system, so they know who they are, who these volunteers are. They have the apps installed in their mobiles running on the background, and whenever they get the call, they can choose to respond to this call or not. So there are two tasks that are expected from these volunteers to do: defibrillation or defibrillator, AED, which means that they need to, when they get dispatched, they get to go to the defibrillator, pick it up and get it to the patient. And the second task is reviving, which is doing the CPR or utilizing AED if they are carrying an AED with themselves. These two tasks are not necessarily separated from each other, which means they can be done in parallel, or if that is the case if we have more than one volunteer. If not, well, one volunteer might do both or just one of them. What we like to have is the presence of more than one volunteer to responding to one case. One can be sent to the AED, the other can be sent to the patient to start the CPR. But having too many volunteers is not also preferable, because they can get in the way of each other when they are helping the patient. They can hinder emergency medical services, and if another case happens overlapping with the first case, what can happen is that we won't be having any volunteer to dispatch to the second case. So put it on figure, we have some smiley, happy volunteers who will participate, and we have some AEDs. What we want to do is to see what volunteers, how many volunteers and what volunteers we will be dispatching, who will be dispatched to where. Which of the volunteers will go directly to the patient, which of the volunteers will go to the AED. And that is to maximize patient survival chance. For doing the model, optimization model, being an engineer also, we have to set some assumptions. We assume that we have a known set of volunteers, so we know what volunteers we have, where they are, how many they are, and we know the set of our available AEDs. We also have deterministic factors, which means that the time that the volunteer will get to the patient or defibrillator is fixed, so it will not change. Also, we consider that there is no probability that the volunteer will not answer to the dispatch call, so they will all answer their dispatch call, and their volunteers are identical, meaning that the time that they can perform CPR and the rest time for all of them are similar. We're disregarding the age and their male or female and their potential time, CPR time that they can do. And also we will assign to each case only one AED. We will not send so many volunteers to pick as many AEDs as possible, because one AED can do so many shocks. So this is the optimization model. I will not go through the mathematical. As you see, there are 23 constraints right now, and some objective function that the survivability function, the beginning, the first part, Niklas will talk about. And in the objective function, we also have some penalty, which is when we have a lag between arrival of the volunteers, because we want to have consecutive CPR or consecutive CPR and AED to keep the patient alive. So if to put constraints simple, what these will do in general will limit our model. Well, obviously, first of all, we'll only send out those that will arrive sooner than the ambulance, and then each volunteer can only be sent either to the patient or to the AED. Well, by that I mean a volunteer can go to the AED and then to the patient, but volunteer cannot do both simultaneously. And also volunteers, as I said, we would like them to arrive in a manner that patient have consecutive CPR. So if we consider that the CPR time is 2 minutes and the rest time is also 2 minutes, for a 10-minute time of arriving on an ambulance will be 2 volunteers to do consecutive only CPR. While the volunteer 1 is resting, the volunteer 2 is doing the CPR, and so on and so forth. But if they will not be able to do so, then we will penalize it. Also, the model will determine the number of volunteers that we will be needing.
Now, okay.
Yeah.
Hi all, thank you for the introduction, Niki.
Yep.
My name is Niklas. I'm a PhD student, and I'm mainly concerned with healthcare analysis at the Division of Healthcare Analysis at the Department of Medicine and Health here at LiU. And I'm also a team member of CARER, which I'm very proud of being, because that pretty much points to exactly what I want to do. I'm very cross-sectional by nature in that sense, and I'm curious, so learning a lot from other researchers is really something that I like a lot. Well, my objectives in this project has been, among other stuff, to actually model the objective function for this. And there are many factors that actually influence the survival and probability of survival in after out-of-hospital cardiac arrest. So in order to actually try to handle these kind of various cases and causes of cardiac arrest, I needed to do some stratifications. And here we have stratified type of event to non-traumatic events, meaning that there has been no accident or, let's say, external damage to the person that caused the cardiac arrest. Also, the type of cause that we limited down to was cardiogenic, in this sense, meaning that it's heart-related, the cause, and then also what type of condition that the cardiogenically caused cardiac arrest patient is in was that it is found in ventricular fibrillation. And this has a pretty serious impact actually on how you model the survival, because if a patient is found in ventricular fibrillation while having cardiac arrest, there is a rhythmable shock, and a shockable rhythm, and meaning that the AED intervention would probably be efficient and might help the patient to survive. So, next task has been to fit a simple model to predict survival among these patients then, and trying to make it as simple as possible, because there's a lot of literature where they bring in a lot of factors, trying to model survival probabilities using baseline characteristics for patients, but also different type of interventions, drugs that you can give to the patient in the pre-hospital phase. But we wanted to look at some decisive factors, and in this case, as it is in many cases when it comes to pre-hospital emergency medical care, it's all about time. So that's the pivotal factor that we try to work around. And from there we got to defining the modeling variables, which were then the time lapse from collapse to the start of basic CPR, and also the time from collapse to first defibrillation. And this Valenzuela, it was already in 1997, suggested some simplifications of these, multi-factor logistic regression functions that were applied to data. And we actually made some further simplifications to the regression model, which you can see here. And since this is still a work in progress, we haven't really collected any data ourselves. So I used some data imputation from polycotomous results from a study by Valevin. And then we estimated a simple model to just fit the data and see what we could get out of it. And then I applied it to some other studies that have collected some real data, among these a Swedish study by Strömsö, and see if the model could be fit to use as a generalizable model to predict survival rates. And as you can see from this figure here, we get this kind of nonlinear relationship between time and survival. And on the vertical axis, you have the probability of survival for the patient found in VF, and on the horizontal axis is the time to defibrillation. And for every curve or these dotted relationships, you see the time to CPR. So the blue dots represent CPR that is immediately initiated at the time of the collapse. And then you see different survival rates depending on how long time it takes to a first defibrillation, given that the patient had CPR from the time of the collapse. And you see that pretty quickly that the survival rates drop pretty fast the longer time it takes for CPR to start. And then also the time to defibrillation has serious impacts depending on when it occurs. And after a while, it doesn't really make much sense to try to use these interventions when time lapses by. Thanks.
Yes. And to see how the model works, yes, I will be needing only 1 more minute. So we did some example scenarios. As Nicholas indicated, we didn't have any real-life data. We haven't collected any data. So we created some scenarios to see how the model works. The first scenario is a relatively small one, set of 4 volunteers, 2 AEDs, and the ambulance arrives in 14 minutes. and the tables indicate in minutes, 7 minutes time to the patient. So if we want to show how it looks like in the figure, for volunteer 2, it takes 3 minutes to reach the patient, but if he or she is to pick the defibrillator 1 and then gets to the patient, it takes 13 minutes for that volunteer to reach the patient. And of course, the ambulance arrives in 14 minutes. After we solved the problem, we saw that volunteer 2 is dispatched directly to the patient. Volunteer 4 will pick the second defibrillator, then gets to the patient. And in considerate of the gap between the defibrillation and CPR, given that there is the rest time of 2 minutes and CPR time of 2 minutes, the survivability of the patient will be 21%. That's the upper bound. But if we consider that there is a gap between the CPR, which is the 2 minutes, then 2 minutes rest, and then AED arrives, the survivability comes down to 20%. Another example is set of 10 volunteers, 4 AEDs, ambulance arrives in 20 minutes. And if we solve the problem when we consider 2 minutes of CPR and 2 minutes of rest time, the volunteer 5 will be sent directly to the patient, and the volunteer 2 will be sent to defibrillator, then the patient. And if we look at here, the CPR starts in 2 minutes, and the defibrillator arrives in 5 minutes. The survivability of the patients without consideration of the gap is almost 32%, but when we consider the gap, it's 30%. Now, if we increase the rest time to 3 minutes, the solution changes. The volunteer 7 is also needed to be dispatched, so 2 volunteers will be sent directly to the patient, and one volunteer will pick up the defibrillator. So the future steps of the project is to improve the model, so the uncertainties and probabilities, such as if the volunteer do not respond to the call, will be considered in the model. We would like to test the model against real data, not just our scenarios, to see how well it performs, and also quantify the benefits of the model to see, we say in percentage, but we want to see utilizing this model, which can be a base for a decision support system, by utilizing it, how many patients can be saved per year. Thank you very much.
Can I just have one remark about what we want to do more with this? Just a second, 30 seconds about it. Well, we've kind of calculated the probability for survival in VF patients, and furthermore, it would be really nice and good to calculate, let's say, the neurological functional outcomes among survivors. How long do they actually survive from being rescued? And is it cost efficient to actually do a lot of intervention in the pre-hospital phase if the patient dies in hospital? That's a really ethical question that could be considered in the more advanced type of modeling. Thanks.